Dr. Karan, what you do is once you finish your talk, just open the Q&A and chat box both, and the student's question please answer last 5 minutes.
Sure, I'll do that.
Both Q&A and chat box. There are two sections. Some people put in Q&A, some in chat. So both open in the last 5-10 minutes, please.
Sure, I'll do that. So should we begin or should we just wait for a couple of minutes?
No, we can start. Arifji, over to you.
Okay. So good morning, everyone. Thank you, NV. Thank you, Professor Somashekar sir, for this opportunity. So we'll be discussing about oropharyngeal carcinomas, basically squamous cell carcinomas today. Why this subsite is a little important is because it's a conduit between both for the airway and the upper diaphragm. So it's a conduit between the aerodigestive tract. So both for the food and for the airway, this is a common passage. So it connects your nasopharynx, your oral cavity to the pharynx and the larynx below. And what is more important for this area is that it's very rich in lymphatics and it has a lot of mucosal surfaces and crypts, so which has a lot of role to play for all the etiopathogenesis that we'll be discussing subsequently. Now, just coming to the basic anatomy of oropharynx. So where does it start? Where does it end? What's the anatomical boundaries? So technically, it's been defined as a space which is bounded by the inferior free edge of the soft palate superiorly, at the level of the hyoid, a plane passing through the hyoid inferiorly. Posteriorly is the posterior pharyngeal wall, which is basically formed by the middle and the superior constrictor and lined by the mucosa overlying it. And anteriorly, it's a plane which passes through the circumvallate papillae and laterally onto the interior tonsillar pillars. So that's what this is. It's like a box. It's a space which is open anteriorly, open superiorly, open inferiorly, and only the posterior boundary is a continuous boundary. What is more important is that it's really lined with mucosa, has a lot of crypts, and then has a lot of lymphoid tissue as well. We are all aware of the Walder's ring. That's the first area where you have a lot of lymphatic structures, and you have the lingual tonsils, you have the palatine tonsils, and this has a lot of implication when it comes to etiopathogenesis of oropharyngeal cancers. Now, as I was saying, there are a lot of anatomical structures in this place. There is the soft palate, there is the tonsil, there is the base of tongue, there is the vallecula, there is the free edge of the epiglottis, there is the posterior pharyngeal wall, there is the anterior and the posterior tonsillar pillars, which we all know are from the palatoglossus and the palatopharyngeus. So it's a very anatomically rich area, which is a lot of structures confined into a very small spot. And what is more important when it comes to oropharyngeal cancers is because we have different modalities of treatment, our information and knowledge about anatomy has to be both outside in, and in oropharynx it has to be inside out as well, and I'll come to that point subsequently. So whenever we study anatomy in MBBS, we are always taught anatomy from outside in. We lift our skin flaps, we go into the structure that we want to study, and then we analyze our anatomy. But in oropharynx, we have to be aware of the anatomy other way around as well. So this is just a cross-sectional image of the oropharynx. The important structures that we have here are the superior constrictor, the buccopharyngeal fascia, the pharyngobasilar fascia, the anterior tonsillar pillar, the posterior tonsillar pillar, the tonsil, the medial pterygoid, the styloglossus, the external carotid artery, the internal carotid artery, and the IJV. And relationship to all these structures is very important because it has a bearing on how you will treat a particular patient. This is what I was talking about. So when you're talking about anatomy of oropharynx, we need to know the outside in anatomy, which is what normally we are more aware of. But at the same time, we have to be aware about the inside out and upside down anatomy. And this is essential when you are planning for a transoral surgery, be it robotic or be it laser, because what you see is upside down and how you follow this patient and resect the patient is inside out. So you need to be aware of your inside out anatomy as well, because the whole orientation changes. It takes a little bit time to get used to this anatomy, and it is very important because every structure is important for your margin when it comes to oropharynx, and we'll talk about it again later. Again, what is very important in this space is that it is highly vascular. There's a lot of blood supply which comes to all of the structures present, be it tonsil, be it base of tongue, be it the pharyngeal mucosa, and all the branches of external carotid artery somehow give supply to this area, be it the tonsillar branch of the ascending pharyngeal artery or the pharyngeal branch of the descending palatine artery or the tonsillar branch of the facial artery. So again, why is this important is because if you are planning a resection of this area, The post-op hemostasis is very important because this is the area where you do not reconstruct. You let the wound heal by secondary intention. And if you are not good with your hemostasis in this area, they can have torrential bleeding. So you need to know which arteries to clip, where to clip it, and which structures would be hampered if you are clipping a particular artery. Again, a very important point when it comes to oropharyngeal spaces that it has a very close relationship to the retropharyngeal space and a parapharyngeal space. These are the spaces which are bounded closely and have close proximity to the oropharyngeal space. And whatever other tumors can have a propensity to spread to this space, or they can have lymph nodal metastasis in this particular area. So knowing this space and its relationship to oropharynx is vital because any lymph nodal metastasis within the retropharyngeal space changes your modality of treatment and changes the prognosis of the patient as well. So you need to be aware of this space. You need to evaluate this space when you are evaluating a patient of oropharynx, and I'll come to the basic evaluation of oropharyngeal cancer subsequently. Now, why this special stress on oropharyngeal squamous cell carcinomas? It just forms 10% of all head and neck cancers, and as for any other subtype, the male to female ratio is 3:1. What is important is the traditional risk factors for oropharyngeal cancers have been smoking and alcohol. And in Asian, South Asian, and Indian population, it is still the most common factor, but it is decreasing over time. What is more substantial and important when it comes to oropharyngeal cancers is that it is one of the subsites which has a viral etiopathogenesis. And human papilloma virus is the most common cause for increase in oropharyngeal cancers, especially in the West. So if you see the percentage of HPV-associated oropharyngeal cancers in India, it's still less than 1/3 of the cancers are HPV related, whereas in the West, majority of the cancers are now turning out to be HPV positive. And we need to know this because it has an implication on the prognosis, not exactly on the treatment presently, but I'm sure the HPV status will have an implication on treatment as well. And the management has been the same as till date, but the prognosis is better, as I said. And because of this HPV epidemic, which has been seen throughout the world, there is an increase in incidence of the oropharyngeal cancers across the globe as well. And this is true for even India for that matter, because gradually our percentage of HPV-related oropharyngeal cancers is gradually increasing. But what has been interesting is this is one of the subsites of the body where the mortality has gone down. Again, it has to do with the biology of the cancers, especially with the HPV-associated malignancies, which tend to do a little better than the HPV-negative malignancies. And we'll go over that subsequently. Again, it's a diverse site with a lot of anatomical structures, so the presentations are very diverse. There can be ulcerations on the palate, on the tongue, on the base of tongue, on the tonsil, on the posterior pharyngeal wall, and each will have some unique symptomatology, but majorly the symptoms are the same. You cannot talk about oropharyngeal cancers without the seminal paper, which was published by Kian Yang et al. In New England Journal of Medicine in 2010. This is the RTOG 0129 trial. And this was the first trial which basically told us that oropharyngeal cancer is not one bucket of cancers. There are two separate biologically independent diseases when you talk about oropharyngeal cancers. And these are the HPV-associated malignancies and the HPV non-associated, or what we call as the P16 negative oropharyngeal cancers. And why is it important to know about these two? Are that these two behave totally differently. Whereas the P16 positive patients do very well, the P16 patients do worse when you are comparing these two groups. And then there is a role of smoking as well. So they basically divided the patients into low risk, intermediate risk, and high risk, where a substantial difference in the 3-year overall survival was found, which was as high as 94% in the low risk and just meager 42% in high risk. So that's why HPV positive is a group of cancers where there are two distinct pathologies that we need to be aware about. One is the HPV associated. I do not like the term HPV positive, and I'll tell you why. So it's more HPV related oropharyngeal cancers, and then there are the HPV negative oropharyngeal cancers. HPV negative oropharyngeal cancers are traditional cancers which behave like oral cavity cancers that we see in India. They are mostly related to tobacco and alcohol. You see it in advanced ages. They present as high T stage infiltrative tumors. They are present with neck nodes, but not as frequently as an HPV-associated oropharyngeal cancers would. The other problem is that because there is tobacco and alcohol intake and there is sweet cancerization, so they are more prone to second primaries, and they don't do that well to radiation and chemotherapy in general. So the prognosis has been till date poor or intermediate. Whereas this HPV associated oropharyngeal cancers is a different biology altogether. They present in younger patients, they present early, they present with big neck nodes. Although the extracapsular spread is a little rarer in these patients, but they present with big neck nodes. The rate of second primary is very low. They do very well with radiation and radiation chemotherapy. So the prognosis is excellent, as we saw from the Yang's paper of 94%. A brief about pathogenesis of the HPV virus. We need to know about the E7 and E6 oncoproteins. So E6 oncoprotein basically leads to telomerase activation and P53 degradation. Both lead to it basically avoids cell death, and there is proliferation of the tissue leading to tumor generation. And E7 basically hinders retinoblastoma degradation, leading to an increase in P16 protein. So P16 protein is basically a surrogate marker for HPV infection, and we use it as an association to find that if a tumor is HPV positive or not. So what we do most of the times is P16IHC. It has its own limitations. We'll discuss that subsequently. Now coming to workup of oropharyngeal cancer, the workup basically remains as it is for any head and neck site. So you have to start with the history of the patient. You have to start about history of alcohol, smoking, sexual habits. Sexual habits take an important precedence when it comes to oropharyngeal cancers because the HPV virus is sexually transmitted. So you need to know about it. Then there are certain signs or symptoms which are more specific to oropharyngeal cancers. These are dysphagia, odynophagia, change in voice. We are aware about the hot potato voice for base of tongue, where the patient talks like there is something being kept on the base of tongue. They can present with respiratory distress, especially if the growth is big and it's covering the airway or the inlet. And they have referrodalgia into the ear of the affected side. This is because of rapid pain along the glossopharyngeal nerve or the vagus nerve, depending upon which side has been affected. What is most important when it comes to oropharyngeal cancers is that you need to first examine the oral cavity because one, it can present with a second primary in the oral cavity. Two, if you are planning a surgery for this patient, you need to see if there is enough surgical access and the mouth opening is adequate. Then you need to do your examination under the anesthesia and a detailed laryngoscopy or a triple endoscopy for that matter. One, to rule out any second primary in the upper aerodigestive tract, and two, to exactly map the extent of the disease and what all structures it is involving. Examination of the neck is done as for any other subsite of the head and neck. Biopsy is a standard and it has to be done for every patient. In very few cases where the site is not accessible or the mouth opening is not adequate, an FNA from the lymph node might also work, but it is not the standard of care. So a biopsy from the oropharyngeal cancer is a must. And if you're doing a biopsy from the oropharyngeal cancer, at least do a P16 IHC in all patients. The CAP guidelines talk about at least a 70% positivity of both nuclear and cytoplasm for P16 staining for it to be labeled as P16 positive. But if you're talking, and if you want to do a study for HPV-associated malignancies, now the world is moving towards ISH and HPV DNA positive testing. This is because there is a slight discrepancy between P16 positivity and HPV positivity. And about 1/4 of the patients will show P16 positivity, but they might not be HPV positive. So there is a false positivity associated with P16, and these cancers tend to do poorer as compared to the HPV associated malignancies. So that's why I like the term HPV associated malignancy and not HPV positive malignancy, because every HPV positive or P16 positive is not truly an HPV associated malignancy. And now if you are planning a different treatment for these patients, you should ideally do double testing. So you should go for a HPV-ish and a P16 positivity. And if there is a discordance, you can do a PCR HPV as well to be definite. The imaging is as it is for head and neck cancers. You do a CT if you are suspecting bony involvement, but most of the times the standard of care or the investigation of choice is an MRI. Because if you are evaluating a base of tongue or a tonsil or a posterior pharyngeal wall, MRI gives you very good soft tissue delineation, and it also gives you great information about the extent of the malignancy into the retropharyngeal space or the parapharyngeal space, and you can exactly see which all structures are involved, because this has a bearing on the modality of treatment that you would be using. And I'll elaborate that point subsequently as well. And PET is done for distant metastasis. You can do an HRCT chest or an ultrasound rolled abdomen, or you can do PET depending upon the clinical scenario. If it's a high stage disease, high nodal stage, multiple nodes, or lower line neck nodes, a PET might be a better investigation. So that's how you basically work up a patient of oropharyngeal cancer. And as I said, as a general rule, HPV positive tumors do better. There are multiple reasons behind it. There are lesser genetic alterations in these patients, so there is homogeneity of the cells which are available in HPV-associated malignancies, whereas there is a heterogeneity in the cellular lineage in non-HPV-related malignancies. These tumors are also less hypoxic, so they are more responsive to radiotherapy. There is absence of field cancerization because there is no exposure to tobacco and alcohol in these patients. There is an immunogenic response which is greater in these patients, so they respond better to chemoradiation. And because these patients present at a younger age with good PS and fewer comorbidities, their tolerance to any treatment is also a little better. So as I was saying, HPV positive tumors are more homogeneous. There are less different cellular populations, so they respond better to radiation and chemotherapy. So the chances of treatment failure are lesser as compared to HPV negative or tobacco associated oropharyngeal cancers. Now, again, why this site has gained so much importance in the last decade or so is because even now AGCC and UICC have started realizing that oropharyngeal cancer is not one bucket of diseases. There are two different biologies altogether. And you can see that in AGCC 8th edition, where the oropharyngeal cancers have been divided into P16 positive and P16 negative malignancies. And when you see the 8th edition, there are certain stark changes which have been made in the TNM staging. One, there is no T4B when it comes to HPV associated oropharyngeal cancers. So what UICC or AGCC is trying to tell you is whatever be the extent of the disease, they do much better than what traditionally has been labeled as a T4B. So this talks about prognostication of these patients. Now see the clinical N and the pathological end staging. There is nothing related to the extracapsular spread in these patients, which has been the standard for any other stage in oral cavity. So clinical N is just about the size of the nodes, whereas the pathological N is about number of nodes positive. They do not talk about the size, they do not talk about extracapsular spread, because these two factors have no relevance when it comes to HPV-associated malignancies. This can also be seen when you are trying to stage these patients. So you can see that even node-positive patients are staged 1. So all they're trying to tell you is that these patients do much better than a traditional oral cavity or a tobacco-related malignancy, and you need to stage them lower as compared to the other subsites of head and neck. Whereas when you come to the P16 negative oropharyngeal cancers, you have both the T4As and the T4Bs as for oral cavity. And similarly, the next stage is similar for oropharyngeal HPV negative tumors as they are for the oral cavity. And when you see these graphs of overall survival and compare the 7th edition and 8th edition, this difference becomes absolutely evident. This was the 7th edition overall survival graph for the oropharyngeal cancer. And once they differentiated the P16 positive and the P16 negative, there is great separation of the overall survival curves. And similarly, the staging system also shows difference and separation if you are separating them based on the HPV positivity. So that's why 8th edition talks so much about P16 associated malignancies, and now it's a standard of care that whenever you are working up a patient of oropharyngeal cancer, a P16 IHC is a must. So make it a habit. It doesn't have a role in treatment planning right now, but subsequently with more data being generated, it will have implications for treatment as well. But presently, you can prognosticate your patients very well if you have the P16 IHC information with you. Now, why all this? And subsequently, side by side, while this P16 epidemic was going on, there has been a transition in treatment of the oropharyngeal cancers as well. This is one area where there has been great development with leaps and bounds, and different modalities have been used in the last 3-4 decades itself. Whereas when you talk about oral cavity, it's still surgery as the primary treatment and radiation or chemotherapy as an adjuvant setting. But oropharynx has seen a tremendous shift over the years. It was an oral surgery to oral surgery of the oropharynx to begin with in early 70s, 80s, and 90s, where people will do mandibulotomies, mandibular swings, do a midline tongue split, do a transcervical approach, and do resection of these areas. The oncological outcomes were decent, but the functional outcomes were very poor. And then came the weird trial in early 1990s, and there was a concept of organ preservation. And subsequently, we started moving towards radiotherapy and then chemoradiotherapy. We were able to cure the same amount of patients with initially lesser morbidity, but then over the time with the meta-analysis which came in 2000, we came to realize that we are treating these patients with lesser initial morbidities, but these patients have a lot of long-term complications with radiation and chemotherapy. And that's the time when there was, again, a push towards transoral surgeries, be it laser, be it transoral robotic surgery. And then also there was improvement in radiation technology as such. We had IMRT, IGRT, and now we have IMPT as well. Then, because of the paper of Yang in 2010, we came to know that oropharyngeal cancer is not one disease. There is HPV risk stratification model which was presented. And now is the time of intensification of treatment for HPV negatives and a de-intensification of treatment for HPV positives. Although both are under trial settings, but that's what the future looks like. So why are HPV positive tumors so different? So this is a meta-analysis which was published in 2017. And these are basically, I've just listed all the criteria that we use to prognosticate an oral cavity cancer. So, and what has been seen is that most of the oral cavity cancers are end stage and extracapsular spread and PNI are the very important features which play a role in prognosticating these patients and to affect the overall outcomes of these patients. When it comes to HPV positive tumors, it's only the higher T stage number of nodes, which is now also being reflected in AGCC staging of these cancers, and LVI, which had some role for prognostication of these patients. Bigger nodes and extracapsular spread had no effect on the outcomes, and that has also been removed from the AGCC classification also. Now, as I was talking, there has been a lot of change in modality of treatment which we have utilized for oropharyngeal cancers, from historically open surgeries to chemoradiation to radiation to chemoradiation, and now coming back to surgery but minimally accessed. So these were the classical mandibulotomy approaches where the mandible was opened like a textbook or the mandible was swinged up, and we used to resect the oropharynx and the mandible was replaced, the floor of the mouth was resutured. So these patients did okay, but there was a lot of functional morbidity that these patients landed up with. They couldn't take orally, there was mandibular disjunctions, there was a lot of ORL, patients were PEG dependent, patients were tracheostomy dependent. So they did well, they did okay oncologically, but functionally they were very poor. And that's why we started moving to radiation. And this was again a meta-analysis published in 2002, which showed that with radiation or radiation chemotherapy in oropharyngeal cancers, the oncological outcomes were similar to open surgery. But see the complications. The complications rates were dramatically lower as compared to oral oropharyngectomies. And that's why the world moved towards organ preservation or radiation with or without chemotherapy. And this has been the standard of care presently as well, because we treat most of the oropharyngeal cancers with either radiation or chemoradiation. But I'm sure as surgical oncologists, we would have realized that chemoradiation alone is also not without its morbidity and mortality. And we all see these patients in our outpatient, where the patients are burnt, they have a lot of mucositis, skin reactions, poor swallowing, a lot of fibrosis, scarring. So we are treating these patients as well as we were doing with open mandibulectomy approaches or mandibulotomy approaches. But in the long term, the functional and this was also evident in the meta-analysis which was published in 2000, which showed that about 30 to 40% of the patients treated with radiation will have long-term sequelae with grade 3 and grade 4 toxicities as well. And a lot of them will also have cranial neuropathies if you are talking about head and neck sites. So that's why we have this revolving paradigm, and there was a need to bring back surgery. So we moved from open surgeries to radiation and chemoradiation, and now we are gradually coming back to surgery. And this has been made possible because we got new toys to play with. let me put it that way. We had great development in laser, and then we had the robotic system, so which made transoral surgeries easier, and we could reach areas where we were not able to reach with our fingers, and we could do minimally invasive surgeries for this area. And TORS became a big boon, especially for HPV positive malignancies. And I would also say for HPV negative malignancies, and I'll show you why. So for early stage HPV positive tumors, this became the treatment of choice because you could resect these tumors well. These patients did not have oral submucous fibrosis, which is related to tobacco use or areca nut use. So the access to these patients' oral cavity was great. You could see these tumors well. You could resect these with negative margins, and you could get away with a single modality treatment for HPV. So what this meta-analysis way back in 2016 showed that about 76% of these early stage cancers of oropharynx could just be managed with TORS alone, and very few of these would have required adjuvant therapy. And now let's talk about management of these patients with each specific subsite. So first, I would like to talk about non-HPV associated oropharyngeal cancers, which is the population what India and Indian subcontinent faces. And this is basically a standard dictum. That is, it's an early stage disease. Try to treat these patients with a single modality. It could be surgery, as in transoral robotic surgery, or it could be radiation alone. And why we talk about a single modality treatment in these patients is because traditionally speaking, open mandibulectomy approaches or open oropharyngectomies and radiation had similar rates of cures. And treatment-related complications need to be taken in account to decide which modality you want to use to address this stage of disease. Also, the management of the neck plays an important role. If it's a midline disease of the oropharynx, bilateral necks needs to be addressed. So do you want to do a bilateral neck dissection or do you want to radiate these necks will also come into play to decide which modality of treatment will you be using. So if you are opting for surgery, opt for smaller primary tumors which have limited lymph node involvements, and these tumors should be amenable to resection with negative margins. And when you have resected these patients, the functional outcome of these patients should be adequate. It's not that you resect something and these patients become an oral cripple. That's not acceptable. So you need to choose your patients well if you are opting for a surgical treatment, be it transoral laser microsurgery or be it transoral robotic surgery. And you prefer initial stage disease because once you have used surgery, always try not to use adjuvant therapy. It's not a rule. If the patient needs adjuvant therapy based on the final stage of the patient, you will look up the patients well so that these patients are treated with a single modality treatment. The surgery can be preferred for patients who are not fit for radiation or chemoradiation, be it medically, or any other cause, or when there is a gross bony involvement. So when there is gross bony involvement, radiation or chemoradiation doesn't do well. So technically these patients will go in for surgery, but these surgeries would have a lot of functional impact as well. So for early stage disease for oropharyngeal cancers, radiation has been the traditional treatment of choice, and this is also the treatment of choice when you talk about unresectable disease or patients have poor functional outcomes or they are ineligible for surgery. So there are certain medical contraindications to surgery, or if it's an early stage disease, you will treat these patients with radiation alone, whereas advanced stage disease traditionally has been treated with chemoradiation. So this has been the standard of care. This is still the standard of care. A lot of different regimes with radiation or chemoradiation are also followed. You can do induction chemotherapy, you can do altered fractionation of radiation. And this basically came from this paper, which was the Marsh meta-analysis, where they tried to compare the conventional radiation to altered fraction radiation. And they also compared the conventional chemoradiation to altered fractionation of radiation. And what they saw was that if a patient is ineligible for chemotherapy or cisplatin, if you do altered fractionation radiation, there is improvement in OS as compared to conventional radiation. Whereas the conventional chemoradiation did at par with altered fractionation. So if you can give chemotherapy, do conventional chemoradiotherapy. But if you cannot give concurrent chemotherapy, then you can consider altered fractionation radiation to improve your oncological outcomes. Now, coming to adjuvant therapy. Adjuvant therapy can either be surgery as salvage, or it could be radiation or chemo radiation after your surgery. So adjuvant therapy is any of these three. And this will basically be based on what you have treated the patient initially, what was the stage of the treatment, and why you are giving adjuvant therapy. So if you have planned for surgery for these patients, adjuvant radiation or chemoradiation are done based on what the final histopathology of the patient will tell you. The chemo, as we all know, the chemoradiotherapy is given for either positive margins or gross extranodal spread, whereas radiation can be given for node positivity, close margins, LVI, PNI. So there are multiple reasons why would you give these patients adjuvant radiotherapy or adjuvant chemoradiotherapy as such. But if you're treating these patients with upfront chemoradiotherapy, salvage surgery becomes the adjuvant therapy. And there is again a great landmark paper in head and neck, which is the PET neck trial published by Messana et al. In 2016. This was a study done in UK where they tried evaluating these patients after concurrent chemoradiation and wanted to see the response to treatment with a PET scan. So they did a 6 weeks clinical evaluation. They did a PET scan at 12 weeks. And based on the findings of the PET scan, they decided either to follow up these patients or to do salvage surgeries in these patients. So there were two components of the PET neck trial. One was the PET positivity, which is the metabolic part of the PET cell study. And the other is the CT, which is the anatomical response of the treatment. If the patient was both PET negative and CT negative, that is, there was no metabolic response at the primary or the nodal site, and there was no appreciable anatomical abnormality seen both at the primary and the nodal site on CT. These patients were kept under clinical observation. Whereas if both the PET and the CT were positive and these patients were labeled as high risk, these patients were taken up for salvage surgery. It could be a salvage neck dissection, it could be a salvage oropharyngeal, depending upon where the residual disease is. What was also important was if it was an equivocal PET response, PET CT response. What that meant was if the PET was positive and there was no structural disease, or there was structural disease seen on the CT component, but there was no metabolic response seen on the PET, they were labeled as an equivocal PET CT, and they did a repeat PET CT at 6 weeks. And based on their findings, if it was still equivocal, they went ahead with the salvage neck. And if the PET component or the structural component disappeared in 6 weeks, these patients were kept under clinical observation, and gradually during the follow-up, if there was any evidence of disease, they were taken up for salvage surgery. So why we need to know about this is that once you have treated the oropharyngeal cancers with CTRT, we need to know how we need to follow these patients. And as I told you, HPV negative oropharyngeal cancers don't do very well with CTRT. So one third of your patients treated with chemoradiation will fail. And we need to pick up the residual or recurrent disease in these patients early so that they can be salvaged with a curative intent. If we don't pick them up well, you will be treating them with palliative treatment subsequently. Again, as I told you, oropharynx has a lot of subsites, and each subsite has some unique problems associated with it when you are operating or radiating them. So for that, for example, if you have a malignancy of the soft palate, and if you do surgery for these, one, you would be removing all of the soft palate in full thickness, and a lot of times bilateral neck dissection and retropharyngeal lymph node dissection needs to be done for these patients. And these patients will land up with velopharyngeal insufficiency. So you might consider treating these patients with radiation or chemoradiation alone, because the functional outcomes with radiation for soft palate might be a little better than surgery. I'm not advocating you don't do surgery for soft palate. We do it, but you need to pick up your patients well. I'm just elaborating what the problems could be based on radiation or surgery for each subsite. Now, tonsillar cancers can be treated both by radiation or chemotherapy or chemoradiotherapy or surgery, depending upon the extent. So you need to evaluate your deep margins well when you are talking about tonsillar cancers, and to see if they are fit for transoral robotic surgery. Same for base of tongue. Base of tongue malignancies tend to spread bilaterally. So if you have tumors which are in the midline, you need to address both sides of the neck. Again, base of tongue is very vascular and has, if you are doing a lot of resection or a compartmental resection for base of tongue, one, there will be swallowing dysfunction, and you also need to talk and decide about the reconstructive options when you are taking these patients for surgery. So, as I say, TORS has been a big boon to oropharyngeal cancers. And why is that? Is because one, it avoids a pharyngotomy or a mandibulotomy or a midline split. It has an ability to operate without line of sight restrictions because you can see around corners because of the angled scope, and the instruments that we have 7 degrees of freedom. There is motion scaling. What the surgeon sees in the 10x view. So the visualization is magnified and great. You can see structures which you would not be able to see with your naked eye. There is tremor reduction. There is precise three-dimensional visualization, and it's an on-block resection. That is a point which has been different from laser surgeries in the past. So when you see the literature about laser surgery, there has been a lot of literature about piecemeal resection, especially when it comes to glottis or supraglottis. Whereas when you talk about transoral robotic surgery, the very big advantage of robotic surgery is that there is an on-block resection of the specimen. So the specimen comes out exactly the way an oral cavity specimen will come out. So you can orient these specimen well. The margins can be assessed very well by the pathologist, and you have a great sense of where, in case you have to revise a margin, if a margin is close or positive, you will know exactly where you want to go back in. So that has been a very big advantage of transoral robotic surgery. And of course, there are these classical 8Ps which have been described, which basically tells you if a patient is ideal candidate for transoral robotic surgery or not. So don't jump on to operate every oropharyngeal cancer with transoral robotic surgery. Select your patients well, evaluate them well, see if they are technically and both oncologically feasible to go for transoral robotic surgery. And if they can, offer this modality of treatment to your patients, especially for HPV negative oropharyngeal cancers. I'll show you why. So again, as I said, every patient of oropharyngeal cancer is not a candidate for transoral robotic surgery. So there are certain indications, there are certain contraindications to this procedure. So easiest contraindication to not doing transoral surgery is advanced disease. If there is a T4 or a T4A or a T4B disease, these are not the patients you would want to take up for transoral robotic surgery, because you will be removing a large part of the oropharynx, and these patients will be doing horribly bad as when you see their functional outcomes. They'll not be able to swallow, they'll not be able to speak, they will be oral crippled, they will be peg dependent, and they will be tracheostomy dependent. Then there are some easier indications of doing transoral robotic surgery. So these are early stage disease, be it HPV associated malignancies or be it HPV negative malignancies. These are the patients who are ideal candidates for transoral robotic surgery, and especially if they can be treated with monomodality or a single modality treatment. Even if you have to give adjuvant therapy, they are still great patients, and I'll tell you why. The best indication is HPV negative, HPV positive non-smokers or HPV negative smokers which are amenable to TORS, because these patients will do really well with your surgery. And of course, there are certain patients whom you are really not sure that transoral robotic surgery will have a benefit or not. And these are HPV positive non-smokers where there's a high probability that these patients will need chemoradiation as well after surgery. And this is the hardest indication. Hello. And this is one of the hardest indications for transoral robotic surgeries, because if you treat these patients with chemoradiation alone, they will do very well. So the real benefit of TORS is not evident for these patients. Again, Weinstein has been the father of transoral robotic surgery, and they started doing a lot of work from 2006 onwards for oropharyngeal cancers and TORS. And these have been the contraindications which have been labeled in a paper by Weinstein and al. Into 2015. And they divided the contraindications into vascular, functional, and oncological. They're basically all common sense based contraindications. So if there is a tumor which is involving the retropharyngeal carotid artery, or encasing
going well, no tension, calm down. इतना मेहनत किया है, God bless you.
Or there are multiple nodes which are abutting the carotid. These are all contraindications to surgery, because you will not be able to get margin on these patients. Then the second group of contraindications are functional. That is, if you're resecting a lot of base tongue or the posterior pharyngeal wall to gain clear margins, these patients will do a lot of, they will do They might do great oncologically, but they will do very poorly functionally. So their swallowing would be hampered, their speech would be hampered. So these are again the patients you will not be keen to do transoral robotic surgery. And then there are certain oncological contraindications. Or advanced stage disease, unresectable neck nodes, multiple distant mets. If there is trismus, if there are prevertebral fascia which cannot be resected, if there is mandibular or hyoid involvement, this cannot be tackled with transoral robotic surgery, or there is extension into lateral neck or eustachian tube are involved. All that means is basically these are the patients who cannot be resected well with transoral robotic surgery and should not be taken up for any surgical modality in general. Basically, this is a diagrammatic representation to specify the extent of oropharyngectomy. So when you are talking about transoral robotic surgery, you don't say that you did a tonsillectomy with a transoral robotic surgery. You label your procedure as an oropharyngectomy, and you need to know what you want to resect in an oropharyngeal resection. So the type 1 resection of oropharynx is when you just remove the tonsil with the anterior and posterior tonsillar pillar and just with the buccopharyngeal fascia. This is ideally not the procedure you would want to do for any tonsillar malignancy. This is what we label as a tonsillectomy in general. The bare minimum procedure that you do for a tonsillar malignancy is a type 2 lateral oropharyngectomy, where you remove the superior constrictor and the pharyngobasilar fascia as your deep margin. And these are done basically for tumors which are limited to the tonsil, not involving the superior constrictor. So superior constrictor forms the base of your resection. And this is the bare minimum surgical procedure that you will do for a tonsillar malignancy. And then you do further resection based on the deep extent of the tumor or the lateral and the medial extent of the tumor. You might remove the styloglossus, the stylopharynges, the medial pterygoid muscle based on what the extent of the tumor is. And your extension to the soft palate, the base of the RMD is again labeled
plate ceremony
ABCD separately.
And placard and
one of the most contentious issues for oropharyngeal resections using transoral robotic surgery has been the margins. Classically, as surgical oncologists, we have all been taught that 1 centimeter is the sacrosanct margin that we need to take for any oral cavity resection. But the problem with oropharynx is that the anatomy is such that it's almost impossible to take 1 centimeter clear margins. And there have been enough studies across the globe to show that for tonsil, a 2 to 3 millimeter deep margin is sufficient, and whereas for the base tongue, a 3 to 5 millimeter deep margin is sufficient. What I'm saying is, it's not that we resect less, but sometimes there is an anatomical constraint to what we can resect. And if you have a clear additional anatomical layer, like the superior constrictor or the fascia, then that's an adequate margin. So it's not that you try to resect less when it comes to oropharynx, but there will be limitations to what you can resect. So if there is a base tongue resection, you don't go for a 3 millimeter margin to begin with. You will try to resect as wide as you can. But if on the final pathology you have a 3 to 5 millimeter clear deep margin, it's adequate. So these are important for both resection and, of course, subsequently deciding the adjuvant treatment in these patients. Now, this is one of the papers that I published, and this is one of the first papers which talked about transoral robotic surgery for HPV negative oropharyngeal cancers, which has been basically the problem of the Asian subcontinent. As I told you, the standard of treatment has been radiation or chemoradiation in the past. And if you go through literature, you will see that whatever the oncological outcomes which were attained in these patients have been static over the last 2-3 decades. And majority of these studies will quote about a 50 to 60% outcomes for these patients. And they have traditionally done worse as compared to HPV associated, where the outcomes have been 90% and above. So we planned this surgery to see that can transoral robotic surgery give us better oncological outcomes. And if you see the results of these patients, almost a 2 years overall survival and a 2 years disease-free survival was in the range of 89 to 90%. So this was the first paper which showed that if you do surgery for these patients, they tend to do much better than chemoradiation or radiation alone, because HPV negative oropharyngeal cancers are inherently radio-resistant. So this was the first paper which showed that there is a possibility to improve oncological outcomes for HPV negative oropharyngeal cancers. Subsequently, we did another study and we included stage 3 and stage 4 HPV negative oropharyngeal cancers. These were the cancers which were T1, T2s, but they were N positive. And again, we evaluated that if we do transoral robotic surgery and give these patients stage appropriate adjuvant treatment, can we improve oncological outcomes in this subgroup of patients as well? One of a lot of people said that you basically use tri-modality treatment in 1/3 of these patients. But my counter to that is that if you are operating on an oral cavity cancer and you get a stage 4 disease, do you not radiate or chemoradiate these patients? You do that because that is a stage appropriate treatment for that patient. And as we know, oropharyngeal cancer in Indian subcontinent is again tobacco and alcohol related. So we have to treat them stage appropriately. So if the patient needs adjuvant radiation or chemoradiation, it's okay. Because if you do that, it significantly improve the overall survival. See, when you're talking about HPV negative, the first thing that we need to know is that traditionally these patients have done very poorly oncologically. So whatever newer modality we need to utilize, we need to improve the oncological outcomes. Of course, not at the cost of functional outcomes as well, but your first aim of the treatment is oncological outcomes. And as you would see in the study as well, the functional outcomes were also pretty good and acceptable in these group of patients with a very good overall survival, which was not seen in any of the studies which treated these patients with chemoradiation or radiation alone in the past. So there is a role for transoral robotic surgery, especially for HPV negative oropharyngeal cancers. But said that, you need to select your patients very well. Again, don't jump on to treat all of these patients with robotic surgery. Evaluate them well. You will see that basically we included T1s and T2s in our group. There were no T3s or T4s, which would have done pretty worse with transoral robotic surgery. So choose your patients well for surgery. And because there has been a lot of talk about transoral robotic surgery in oropharyngeal cancers, there has been a lot of classification systems which have started coming in based on the amount of resection you will do and how you would want to reconstruct these patients. So just to briefly tell you, if you have a TORS defect and there has been a more than 50% palatal defect, or there has been a posterior pharyngeal wall resection, or there is a communication with the neck, these are the patients who will need some form of reconstruction. If your carotid is exposed in the bed of the resection, these are the patients who will need some form of reconstruction. It can be a local flap, it can be a regional or a free flap, depending upon the expertise available and the amount of defect you need to cover. So it's not that all transoral robotic surgery defects can be left to secondarily heal. Bigger defects will need some form of reconstruction. And just a brief principle that for soft palate, you can do local flaps. For smaller resections, you might do a radial forearm flap. For a larger dissection, so it's all common sense that larger the defect, more the tissue, you might need a regional flap or a free flap for the defects. Again, if you're talking about oropharyngeal cancers, you cannot do without discussing the ORATOR trial. This was the first randomized controlled phase 2 trial which was published for oropharyngeal cancers, where they tried to compare radiation with TORS. It has a lot of lacunas in the study, but I'll just briefly go over the results. What they tried to evaluate was the functional outcomes of these patients, and they used the MDADI scores. And what they saw immediately when they finished the study was that there was slight improvement in MDADI scores in the RT arm as compared to the transoral robotic surgery arm, but there was no statistical significant difference between the two. And when they evaluated these patients after 2 years, even this difference was not there. So both the arms did exactly the same. So there was a lot of hue and cry when this trial came out, and TORS was basically condemned that these patients don't do well. All these patients should be treated with radiation. I would advise everyone to read this trial well, because there are a lot of lacunas, there are a lot of shortcomings to these trials. But what was very important, which came out of this trial as well, was that majority of these patients were again HPV positive. Only 8 in each group were HPV negative. But see at the outcomes of HPV positive and HPV negative in this trial also. The P16 negative tumors treated with radiation did worse as compared to the P16 positive tumors. So the point is that, again, HPV negative and HPV associated malignancies are way different. So any extrapolation of data from the West for HPV associated malignancies cannot directly imply to our group of patients, which are majority P16. So we need to have P16 negative specific data or data from Indian subcontinent, which might change practices for us. So again, now talking about the HPV associated malignancies, they definitely do better than HPV negative malignancies, and there has been a lot of talk about de-intensification of treatment in this group. These are all experimental and under clinical trials, but as DNB surgical oncologists, we need to know about the de-escalation therapies in HPV associated malignancies. And these are basically for low risk HPV positive tumors. And why are we talking about de-escalation is because these patients do so well oncologically, we need to preserve their oropharyngeal function and reduce the potential toxicity associated with standard treatment choices. So you can de-escalate the treatment in a number of ways. You can just do surgery and go do away with radiation or chemoradiation and treat these patients with single modality. You can lower the dose of adjuvant radiation. You can do induction chemotherapy and de-escalate the radiation dosing. You can reduce the dose of definitive radiation upfront as well, and you can substitute cisplatin or carboplatin with less toxic drugs. And all these modalities are being tried across the globe in various trials, the results of which would be out in the subsequent years. But these are all for low risk HPV positive patients. So it is not for every HPV associated malignancy. So what you need to do is you need to know about risk stratification in HPV associated malignancies. And these are the patients which are early stage, low neck nodes, non-smokers with no other adverse feature, which are the patients which are apt for de-intensification treatment. For patients who are smokers, they don't do as well as non-smokers, so you need to titrate your treatment again for these patients. And this is seen in the NCCN guidelines as well. And NCCN basically divides the guidelines for both HPV associated and HPV non-associated malignancy. And this is just a gist of the NCCN guidelines. What is important to understand is for early stage diseases, NCCN tries to advise for a monotherapy, which is understandable. You want to treat these patients with a single modality of treatment. It can be surgery, it can be radiation. But as the nodal stage goes up, the oncological outcomes are not as good. So you will have to use a multimodality treatment. It can be chemoradiation, it can be surgery followed by radiation. Again, depending upon the extent of the disease, your evaluation of these patients, the surgical expertise available at your center, that is what makes you decide how you will treat these patients. When you talk about P16 negative tumors, it's only the very early stage patients which are treated with monotherapy. But as the end stage becomes N1 or the T stage goes higher, these all patients need to be treated with multimodality treatment, because these are the group of patients who do not do oncologically as well as P16 positive tumors. So you need to treat these patients with a stage appropriate treatment. It can be surgery followed by adjuvant therapy based on the final histopathology, or it could be upfront chemoradiation. So these are not the patients who are ideally treated with a monotherapy of radiation or surgery alone. And I'll not go through all these slides because all of us are well aware what the NCCN guidelines talk about. But what is this I wanted to point out was that all of these guidelines are specifically differentiated for P16 and P16 negative and positive tumors. Majority of the treatments remain the same. As I initially also said, we need to know this P16 status, but the treatment is not very different. Treatment is still with radiation, surgery, or chemoradiation, but the prognostication is different. But do the P16 IHC for every oropharyngeal cancer, because once we generate this data, would we know that can we change the treatment for these two patients also? And this is all the NCCN guidelines which are available for everyone. Now, before I end, a last word about HPV vaccination and oropharyngeal cancers. So there has been a lot of stress for HPV vaccination and cervical cancer in general. And this basically started from the West, and even now there has been a push in the Indian subcontinent as well. And this has become a part of the vaccination protocol for girls and women in India as well. And what has been seen in the past in the West over the last decade or two is that there is gradually a decrease in cervical cancer rates in the West. We have just started doing HPV vaccination in India, so we don't have the effects as evident. But it's common sense, and it's a corollary that we can extrapolate from cervical cancer. That if the rates of cervical cancer come down with HPV vaccination, the oropharyngeal cancer rates will also come down. And in the West, it is now advocated for boys as well. In India, it is optional, the boys can take it, but now it is advocated for girls and even ladies up to the age of 40, I suppose. And but there are certain riders which have to be met. The patient, the girl or the lady has, the girl has to be sexually inactive. There has to be no multiple sexual partners. But as the HPV vaccination will become a common scenario in the Indian subcontinent, maybe the rates of cervical cancer and subsequently the oropharyngeal cancers may come down. So boys and older females are secondary targets of vaccination. Young girls are the primary targets for oropharyngeal or for HPV vaccination across the globe. So this is just a tabulated form for whatever we have discussed so far. That if you have an early stage disease of oropharynx and if it's HPV related tumor, you can do radiation or primary surgery, opt for any one of them so that you can treat them with a monotherapy. For an HPV negative tumor, primary surgery might do a little better with whatever limited evidence that we have, the two papers that I showed. Whereas if you have an advanced stage disease and it's HPV positive, try to do chemoradiation because you will, with primary surgery, you will be using 3 modalities of treatment. For HPV negative malignancies, primary surgery may still score a little better than chemoradiation. It's a little contentious because these are the patients who will be requiring stage appropriate treatment and the oncological outcomes might be a little better as compared to just chemoradiation in these patients alone. But these are again under trial settings. These are not sacrosanct guidelines. Again, you will have to take these patients stage based and individual based. With this, I would end my presentation. Thank you.
Thank you very much, Dr. Karan. That's actually a fantastic presentation you did and very comprehensive, very nice and heartfelt thanks from our side. Beautiful lecture, very comprehensive, to the point, very evidence-based. I would request if Dr. Kalsubai is there to take through the discussion and also give his inputs, please. And at the outset, I really want to thank from my side and the NBA, TNB board for all the hard work Dr. Kalsubai does for the benefit of students. He and Dushyant, fantastic. It's not an easy job. They decide what topic, how to do, speak to all the top faculties who gets their time and did. Kalsubai, heartfelt thanks. Ever grateful to you on behalf of the National Board and DNB. Over to you, Kalsubai.
Thank you so much. Our efforts are, compared to your efforts, are much less. You are steering the entire education program in NBMS on the online lectures, all this, and we are happy that we are part of your efforts now to support DNB students. Dr. Karan was chosen one of the highest experience of treating oropharyngeal cancer. He's one of the first, or not one of the, he is the first robotic fellow of the country for head and neck. And he has published so many papers on robotic surgeries and treating oropharyngeal cancers. Karan, thank you so much for agreeing to deliver this talk.
So it's an honor to share whatever virtual podium with you and Dr. Somashekar sir. So thank you for having me.
Yeah, so now I have 3 comments. One is that oropharyngeal cancers have more propensity for synchronous or metachronous second malignancies. So when you do your workup, you should be aware about the possibility of second malignancies in these patients, and that's why PET scan is a modality which, if possible, you should utilize in these patients when you are evaluating them. The second point towards treating early T1, T2, and I would say even N1 oropharyngeal cancers which are appropriate for surgery by TORS. The reason is that there are different scenarios. If this T1, T2, N1 is ultimately pathologically N0, you are actually avoiding two modalities of treatment which would have been a chemoradiation for that patient, which you are doing only TORS, only surgery, and these patients are not given any adjuvant treatment. So that is one scenario. Second scenario is that if they are really positive, if N1 is positive in your final histopathology report, then also you are not giving chemoradiation, it's an adjuvant treatment with radiation only. And if there are multiple node positive, then also the treatment, if at all you are giving chemoradiation, the dose of chemoradiation is much less than the curative chemoradiation which you will give. So overall the toxicity would be much less in these patients. So that brings out the caveat for doing these management. And the third thing would be that whenever you do the second paper of Dr. Karan, which he projected, T1, T2 with N plus N2, N3 diseases where they did TORS followed by chemoradiation. You must understand that there is a possibility, and there are many centers in the world which will not radiate the oropharynx while giving this adjuvant chemoradiation to these patients, because your T1 and T2 are optimally resected by TORS, margins are clear, and so you don't need to radiate the oropharynx, you just need to radiate the neck because of N2 and N3 disease. So these are the advantages I would like to put up, that whenever there is a discussion in your exam regarding TORS versus radiation, these are the points you can put up.
Fantastic. Very, very good points. Excellent. I remember when I was doing MCH in GCRI, anything behind the circumvallate papilla is just beyond surgery. But now with the advances, and then we used to see the complications and the salvage surgery, quality of life. But now with as Karan showed, with the advent of surgical technology and everything now from there, even up to, tip of the base, tip of the pyriform fossa, you can go in and operate. Thank you. There are one or two questions. I think, Karan, you can just open and answer them.
Yes, sir. So one of the questions is why TLM is not preferred after chemoradiation for salvage surgery. So it's not that TLM is not preferred after chemoradiation. There would be certain subsites or certain indications where you can use transoral microsurgery, especially for glottis. For that matter, there is enough data to suggest that you can do salvage cordectomy even for early glottic cancers who have failed radiation. The problem with, not a problem, basically one of the shortcomings of TLM is that it's an in the site resection. So you can't resect along angles or along corners. Whereas with robotic surgery, you have the visualization across corners and you can resect out of the line of vision as well. So that's why when it comes to salvage surgery, robotic surgery is usually preferred, but it's not that transoral microsurgery cannot be done as a salvage procedure. So that's one. The second question is, as DOI is an important prognostic factor for anterior two-thirds tongue, where does it stand in respect to base tongue and CA oropharynx? So in general, based on the AGCC classification, DOI is an important criteria for every subsite of head and neck. But so DOI would also be a criteria for you to decide adjuvant therapy when it comes to base of tongue or oropharynx in general. But it's not that your management is a little different as compared to any other subsite of the oral cavity. So it's an important prognostic indicator for base of tongue also. But base of tongue, you can resect more into the extrinsic and the intrinsic muscles. If you would remember, there was also a part of initial AGCC which talked about extrinsic muscle involvement, which was labeled as C4, and they removed it subsequently from the 8th edition because radiologically they were not able to, pathologically they were not able to differentiate the extrinsic musculature. But the base tongue is majority of it is extrinsic muscle only. So resection of that is feasible. So DOI plays an important role, but it is not as important as the anterior two-third tongue for prognostication maybe.
So, the question of TLM or even TORS for salvage surgery has two issues. One is if the tumor is more in the oropharynx, you can, and if you can do transoral robotic surgery, you can do a salvage surgery, TORS assisted, where you don't have to do a mandibulotomy and do the resection from inside, and then you deliver the specimen from neck when you do a neck dissection with it. So this is possible. The problem with chemoradiation and salvage surgery is that with chemoradiation, many patients don't have an adequate mouth opening. So that's the reason why you cannot put robotic or transoral laser surgeries into these patients. And that's the reason why it's many a times it is an open surgery as salvage.
Fantastic. Thank you very much. As I always say, all good things has to come to an end. And the whole purpose of mentors and teachers like all of you is not spoon feeding, because our boys are not in UKG, LKG or nursery. They are grown-up surgeons. The whole purpose of a guru is to show the direction and stimulate their mind, and they have to walk that path and expand on that, take the guidance from us. These are such huge topics. We can run 3 days, 4 days seminar series, and yet we may not able to complete the entire thing only on oropharynx. So students, it's your honor. You must know the value of top faculty like Dr. Karan, Kalsu, who leave their busy work and come for you. Take all the cue from them, expand on what they told, and walk in the direction they took. They're always available in conferences privately for one-to-one discussion later. Please utilize this. It's impossible even to go and meet them, even if you are in the same city. They are such busy people. And thanks to NB board and their commitment, they are coming and helping. Thank you very much, Kaustubhai, Karan. As I always say, from DNB board, we can't give you anything for people who already have everything, you both, but we can give a blessings to you and your family for the good teaching work you're doing for us. Thank you very much. And over to you, Arif Ji. Thanks.
Thank you so much, sir. Thank you.
Arif Ji, over to you.
Thank you, training and faculty members, to join the webinar. Thank you, sir.
Thank you. Have a nice day. Bye-bye.
Bye.